Today's VETgirl podcast is sponsored by Blue River Pet Care. The vet med field is always changing. So are you. Celebrate the new year by finding the perfect practice for your DVM lifestyle with Blue River Pet Care. With nearly 200 locations across the country, you can choose to practice medicine in the mountains, among the bright lights of a big city, or anywhere in between. Advance your profession and your passions with a team that supports and celebrates each chapter of your life. Visit mydvmlifestyle.com to make 2025 your best year yet. Hi, VETgirl here today, and I'm super excited to speak with one of my longtime veterinary colleagues, Dr. Leah Cohn. If you guys haven't heard her lecture before, she is amazing. She's the only person I say yes to for book chapters, and I've gotten really good in life about saying no. So one of my favorite people. She's an internal medicine specialist and a professor in internal medicine on faculty at Mizzou at University of Missouri. Dr. Cohn, thank you so much for joining us today.
Thank you so much for having me, Christine. I always love to talk to you. It's so much fun.
Thank you so much. So just so our audience knows a little bit more about who you are and where you train, do you mind just giving us a little bit of background about you?
Sure. So I'm a graduate of the University of Tennessee from a very long time ago. I then went to North Carolina State, where I did an internship and a residency and a PhD and then a postdoctoral fellowship. Then I got my first real big girl job at the University of Missouri, and that was almost 30 years ago. I've been here ever since in all sorts of roles, including a recent 3-year stint as various sorts of interim dean. But what I love to do is treat animals.
All right. So let's talk about some more misconceptions or myths, or even what we call outdated beliefs. If you haven't already listened to part 1, please make sure to check that out, because we talked about some really important updates, things like lepto, to using the appropriate indications for gastroprotectants in our hospitalized patients, or even for chronic kidney disease. We talked about fluid therapy. We talked about steroids. And Dr. Cohn, I wanted to talk to you about antimicrobial stewardship and therapy. I remember when the ISCAD guidelines came out years ago, they were mind-blowing, because we have always treated urinary tract infections for like 10 to 14 days, right? And I remember going to a human medical doctor for UTI, that's way TMI, but that's okay, 20 years ago. And I was like, 3 days of tribrissin? What, are you kidding me? And like, that's all they do, right? They do 3 days of a sulfa or some type of appropriate antimicrobial. So human medicine has been treating uncomplicated UTIs for a very short duration with antimicrobials compared to veterinary medicine. So tell me what's new with antimicrobials when it comes to UTIs. And then I also wanted to ask you, should we be treating every animal that comes in with bacteriuria?
Absolutely. Those are fantastic questions. Let's take the should we be treating every animal first. And as we mentioned in the last time, ACVIM has a number of consensus statements and guidelines that are open access. Anybody can get a hold of any of the publications in the Journal of Veterinary Internal Medicine. And I would urge everyone to take a look at the ISCAID guidelines for urinary tract infections, which are also open access, although they're not in JVIM. They're working on an update, by the way, of those ISCAID urinary guidelines, so we should have an update coming out soon. But they put in those guidelines really some of the first attention to not necessarily treating subclinical bacteriuria. And what is subclinical bacteriuria? Well, it turns out that you can have bacteria in your urine. They're really there. You can see them, you can culture them, but they're not causing an infection. Remember, we can have bacteria in us and on us that aren't necessarily pathogenic. And I'm not just talking about the microbiome organisms. I'm talking about all kinds of organisms. If you were to take your hand and put it on a petri plate, you would grow all sorts of organisms. There'd be lots of things growing up, but your hand's not infected. It's just got bacteria on it. And the same thing can be true in other places, and that includes the urinary bladder. It's less likely to have bacteria that you grow on just a routine culture, but having bacteria is not the same as an infection. An infection is characterized by redness, heat, swelling, pain, and loss of function. If there is none of that stuff, there's no inflammation, there's no infection, it doesn't necessarily need to be treated. So the guidelines say if there's an animal, even if you see bacteria, even if you grow bacteria, you don't have to treat for bacteria. if there is no evidence of an infection, redness, heat, swelling, pain, loss of function, those type of things that tell us there's an infection. And that is certainly true for human beings. It has been for a long time. Asymptomatic bacteriuria, of course, people can report symptoms. So dogs don't get symptoms, they get clinical signs because they can't report them themselves, which leaves us open to a couple of places where maybe it isn't quite as easy. If we think about subclinical bacteria, yeah, fine. If it's a happy, healthy dog and I notice there's some bacteria there, I don't need to treat it. But what if it's not a happy, healthy dog? What if it's a dog who has an intervertebral disc and it's paralyzed in the back and it doesn't feel anything in the back? It doesn't even feel me pinching its toes. How's it going to feel a bladder? That's another question. It's not so easy because how are they going to demonstrate clinical signs if they don't have any control back there? Another difference between the human beings and the dogs, aside from the paralysis and paresis and the neurologic things, is that when we're talking about having bacteria in your urine, maybe it's diluted because the urine's really dilute because you have diabetes mellitus or hyperadrenocortisolism. So it doesn't have those clinical signs just because it's a more dilute urine. Should we be treating diabetics when they have bacteriuria? That's a debate. I have colleagues who are internal medicine specialists who would say absolutely not. It's subclinical bacteriuria. If they don't have any clinical signs, don't treat the diabetic with antibiotics. I have other colleagues who would say absolutely yes, give them antibiotics. They're a diabetic, they're relatively immunosuppressed, their urine is dilute. We don't have the final answer there. We don't know the answer. And then another situation that makes it a little bit different from people versus animals is how our surgeons deal with it. One of my colleagues here, who's an oncologic surgeon, he wants to treat subclinical bacteriuria before he does surgery. And we've had this argument. I'm like, they're subclinical. They don't have any lower urinary signs. They don't need the antibiotics. And his point is, yes, but I'm about to make an incision on their skin. They're going to lay in a cage, and they may be laying in urine on their incision. People don't generally lay in urine on their incision after they have an abdominal surgery. It'd be highly unlikely you're going to urinate on your abdominal wound after a surgery or on your leg wound. Even if you have your knee replaced, you're probably not going to urinate on yourself. But if an animal has bacteria in their urine, they might get urine in their wound. So should we be treating in those cases? We just don't have evidence for that right now. But in general, for the most part, having bacteria in the urine without any evidence of an infection, which is usually associated with inflammation, redness, heat, swelling, pain, loss of function, we should not be giving antimicrobials for the most part. So now let's talk about what if we do need to give antimicrobials? What if they do have plaqueuria or dysuria in some form? So we do want to treat those animals with antimicrobials. You're absolutely right. In human beings, the treatment course is quite short, 3 days sometimes, and sometimes even 1 day. Some of the antimicrobials they use, they literally do a 1-day treatment. We used to, when I went to vet school, everything got 14 days of antibiotics for a urinary tract infection. We now know that's way overkill. We don't have to do that. The ISCA guidelines suggest that we should be treating for 3 to 5 days for clinical lower urinary tract infections. Now, 3 to 5 days, if you're really, really honest and you look in the literature, not every kind of antimicrobial has been evaluated. There are studies that have looked at clavamox for short courses. There are studies that have looked at trimethoprim sulfa for short courses. There are studies that have looked at fluoroquinolones for short courses. There are not studies that have looked at plain old amoxicillin for short courses. The ISCA guideline still calls for 3 to 5 days, even if you're using amoxicillin for your antimicrobial. And by the way, amoxicillin is one of the first choice go-to empiric treatments while you're waiting for a culture susceptibility, or if it's a simple UTI, instead of a culture and susceptibility, they're recommending amoxicillin as a first choice. There are no studies that look at those short courses, but we believe that it works. So first thing, you don't treat every animal with bacteria in their urine. But if they have clinical signs that could be due to bacteria in their urine, then you're going to treat them. Generally, you're going to treat them for a short course. There are complications there too. Like, what do I do if I have a dog that has struvite uroliths? Well, we know struvite uroliths in dogs are usually associated with infections, maybe a staph infection or a proteus infection that caused an alkaline pH. So I start them on an antimicrobial. If I only give 3 to 5 days and I'm dissolving that stone and I stop the antimicrobials and the stone dissolves another layer, now there's bacteria being re-exposed to the bladder. So it essentially can be reinfecting itself with every layer of the stone that dissolves off. There may be bacteria incorporated in there. So for stone dissolution, I am still using a longer course of antimicrobial until that struvite stone dissolves. Now, I had a dog just literally day before yesterday that has calcium oxalate stones and a urinary tract infection. It's not with a protease or a staph that are urea splitters. It was an E. coli. So I think that we always have to ask, is it a chicken or the egg? Is it that the infection caused the stone, like we think of in struvite, or is it that the stone caused the infection? When you've got stones in your bladder, it's rocks rolling around in your bladder, breaking up the epithelium and injuring it, and that can predispose them to developing an infection. So this dog that I think has calcium oxalate stones got a short course of antimicrobials for the E. coli in his urine because it's having clinical signs of a lower urinary tract infection. Now, I realize maybe those lower urinary signs are because it's got stones, not because it's got the infection, but this is what I could take care of right now while we figure out how we're going to deal with the stone. And if in fact I get rid of the infection and the clinical signs go away in this dog, it buys me some time to figure out what to do about the stone.
Great, great information. Really appreciate that. I know it's often difficult in clinical practice because sometimes the owner won't go for that urine culture, which can be quite expensive. They may not even be able to pay for urinalysis, or sometimes some of these patients have such a small bladder from that pollakiuria, we can't actually get a sample. But again, ideally, we want to practice the highest level of care. So love these guidelines. With that said, I wanted to talk a little bit more about antimicrobial therapy, especially when it comes to surgery and treating my favorite, aspiration pneumonia, right? So first of all, say a dog has a clean surgery. When should we be using antibiotics? I know depending on where you practice, the surgeons always like to use something intra-op and typically 2 hours if the surgery was going on for a long duration of time. But oftentimes, 20 years ago, they would automatically send them home on, 2 weeks of some kind of cephalosporin.
Yeah.
What's the newest standard of care? If it's a clean surgery, do they need to go home on antimicrobials?
Absolutely. If it's a clean surgery, they should not have to go home on antimicrobials. Now, I know that there's some exceptions to that. Even veterinarians that I work with who are orthopedic surgeons, if they put in plates or some sorts of implants, they may want to continue the antimicrobials longer. There are some papers that suggest it might be useful. So we'll take away the animals that have a bunch of hardware going into their incision and just talk about the other sorts of surgery where you go in, you do something, you close it up. There is no indication for a clean surgery of continuing antimicrobials afterwards. I went to a talk fairly recently in human medicine, so it wasn't veterinary medicine, but they had something that I thought was just a really profound statement, and I'm going to go ahead and say it here. They said that surgical antimicrobial prophylaxis should be used like a condom at the time of the event and not afterwards. So there I said it for what it's worth. We use it right during the surgery, but don't continue it for weeks afterwards.
Love it. Love it. All right. What about like a dirty surgery, like a pyometra?
Okay, that's very interesting too. So there is a textbook, Cote's Clinical Veterinary Advisor, that I've been privileged to be a co-editor of, and co-editor in chief with Etienne Cote. And this time out, it's just me. He's worked on the Ettinger textbook of veterinary internal medicine. So I'm editing the 5th edition of the Clinical Veterinary Advisor myself. And I was reading the new chapter on pyometra. And the author did not recommend continuing the antimicrobials after removing the uterus. I'm like, what? And I am very careful about my antimicrobial use. I try to be a really good steward of antimicrobial use. But to me, it was a little bit mind-blowing And I even contacted the author and I'm like, hey, is this really what you intended to say? And she's like, yeah, that's really what I intended to say. And there's evidence out there. If you are removing the uterus as a bag o' pus with bacteria and the animal's not septic, so it doesn't have infection that has spread through the body, once the bag o' pus is out and you've used antimicrobials at the time of the surgery, they don't continue the antimicrobials afterwards. Now, obviously, it is different if they are septic, if those little bacteria have gained access to the bloodstream and spread through the body, and there's evidence of sepsis, all the good things like hypoglycemia and leukopenia and left shift and fever. If those things exist, yeah, then you will treat with antimicrobials, you will treat with antibiotics. But if it is just a pyometra and you remove the uterus, no, you don't continue the antimicrobial therapy, which is mind-blowing to me.
It is, it's crazy. I always say I'm amazed how much the uterus can stretch.
Mm-hmm.
Same with the bladder.
Mm-hmm.
But thankfully, we rarely see them rupture unless it's iatrogenic. In other words, we did a cysto on a female intact ADR dog or cat and resulted in, rupture of the uterus. So I do think it's interesting. It's hard to see that bag of pus and then not treat them. But again, standard of care, right? Yeah. So very, very interesting. Okay. Dr. Leah Cohn is going to make us lose our kid-friendly status on this podcast because of the use of condoms and pus, but that's okay. I love it. All right. Now talk to me about aspiration pneumonia. I was trained by Dr. Leslie King, who was an amazing criticalist, and we were always taught at Penn we had to keep them on antimicrobials when they were diagnosed with aspiration. And it was typically for weeks, usually 3 to 4 weeks. Mm-hmm. And they'd had to come back in for chest rads. And we would always continue the antimicrobial therapy for, 3 to 5 days post resolution of disease, radiographic disease. And first of all, it's hard because with the growing cost of veterinary medicine, chest radiographs are up to $400-$500, right? So it's expensive for a pet owner to come back frequently for that. And the second thing is, when I was taught in vet school, I remember my mind was blown when one of the most brilliant internists, who will stay unnamed on this podcast, said, so much in vet med is made up. We say the swelling goes away and hot pack it for 3 to 5 days and exercise restrict them for 5 to 7 days and treat them with antimicrobials at 10, 14 days. But there's no literature. We just make that stuff up. And I was like, what? But it's probably true, right? So aspiration pneumonia. Talk to me about treatment when it comes to antimicrobials.
Yeah. First of all, Leslie King was a wonderful, wonderful veterinarian, and I very much admire her. And all those things she told you would have been the same things that I would have told you at that time. But when we know better, we can do better. And we know better now. So aspiration pneumonia is not necessarily a bacterial infection. Aspiration pneumonia is when you get contents down into your lungs that shouldn't be there and it causes damage. And obviously, most often that's going to be GI contents that end up down there. And so if you end up with acid in your lungs, that's going to cause damage. But it's pneumonitis, not pneumonia. Your stomach actually doesn't have very much in the way of bacteria. It's a vat of acid. There's not much bacteria down there. So aspiration pneumonia doesn't typically start with a bacterial component. Now, you're going to damage your airways and damage your lungs, and maybe you will develop a bacterial infection afterwards. But aspiration pneumonia should more properly be called aspiration pneumonitis. I still call it pneumonia. There are now more and more studies being done, many of them led by my colleagues, Dr. Ida Vientos-Platz and Dr. Carol Raniero, both fantastic veterinary internists with great respiratory expertise. They are finding that most animals with aspiration pneumonia don't require antibiotics at all. They just don't need them. The other supportive measures, whether that's supplying oxygen or airway humidification through nebulization, any of the other supportive things they need, they get better without ever seeing a dose of antibiotics. And I used to be just like Leslie King. I always gave antibiotics because it's like, that's what I can do. I can treat with antibiotics. But antibiotics have downsides. We know that they change the microbiome, the microflora. They have potential for adverse effect. They have cost. They have inconvenience. There are lots of potential downsides to using them. So more and more and more here at the University of Missouri, we do not treat most of our dogs with aspiration pneumonia with antibiotics at all. Now, some of them will get antibiotics. Fever is not a perfect indicator of a bacterial infection because you can have a fever just from the pneumonitis, and you can not have a fever even when you have bacterial pneumonia. We were talking about in Journal Club just this morning that we don't have a simple non-invasive way to say whether this is a bacterial infection or not. There are studies that have looked at swabs from the back of the throat for culture, not a good marker for whether there's bacterial infection in the lungs. There are studies that have looked at blood cultures, not a good marker. So what you'd have to do is actually get a culture from deep down in the airways through something like an endotracheal lavage or bronchoalveolar lavage, and then you have to culture that and see if the bacteria grow. Well, that requires general anesthesia, even if it's brief and it's somewhat invasive. And you've talked about cost a few times. There's costs associated with that. There's real cost. Plus, some animals don't recover so smoothly, so maybe it's another day in oxygen or in the ICU. So there's some downsides to doing it, but that's the only way to know whether it's an infection. So first of all, I want to say you don't always have to treat with antibiotics at all for aspiration pneumonia, but if you do treat with antimicrobials, how long do you treat for? In human medicine, the standard now for most community-acquired pneumonias is that they only treat for 5 to 7 days, and they don't do any sort of follow-up with thoracic radiographs. We now know that thoracic radiographs lag way behind clinical resolution of pneumonia. There are multiple studies that show this, tons of them in human medicine, but even in veterinary medicine. So even after the animal is breathing just fine and they're oxygenating just fine, their radiographs can still look like a bad lung. So while I absolutely used to talk about taking repeat radiographs after 3 to 6 weeks of antimicrobial treatment and continuing the treatment for 2 weeks more after radiographic resolution, that was a ridiculously long time to use antimicrobials. There have been some studies looking at alternate measures like C-reactive protein to see if that might be a better way to judge. There are some indications that perhaps that might be useful, but really that's looking for inflammation, not infection. So we can't kid ourselves and say C-reactive protein is looking for the presence of bacteria. Dr. Vientos-Platz and Dr. Raniero did a nice study looking at a couple of different durations in a prospective blinded manner for aspiration pneumonia when they did treat with antibiotics and they thought that it was bacterial. And it turns out that a 10-day course of antimicrobials was every bit as good as a 21-day course of antimicrobials. So the old thinking of treating for 3 to 6 weeks or 2 weeks past radiographic resolution is just wrong. So first of all, we may not even need to use antibiotics for aspiration pneumonia. And if we do use the antibiotics, we don't know the optimum duration, but it's probably closer to the 10 days than it is 2 weeks after radiographic resolution. And it may be much shorter than that. Maybe it's going to be more like the human beings where it's 5 to 7 days.
You know, it's interesting. I think if you've ever been on oral or IV antibiotic, your gut is crushed.
Yeah.
Right. And that's probably one of the reasons why humans just can't tolerate being on antimicrobials for so long. The blowout diarrhea is just terrible, right? As much yogurt as you're going to eat. So that leads me to my next question. Antimicrobial therapy with diarrhea. Now, I wish you smart people would stop renaming things so many times because I can never remember what the new name for HDE is. But when it comes to hemorrhagic diarrhea, I wanted to talk to you about whether or not we should be treating acute diarrhea with antibiotics. And I will say in very severe cases of what we formerly used to call hemorrhagic gastroenteritis or HGE, which is now acute hemorrhagic diarrheal syndrome, I sometimes will, but sometimes I see these patients that are borderline septic. They're leukopenic, they're hypoglycemic, they're hypotensive, they're hypovolemic and dehydrated. But this is not the classic, like, I'm a Westie coming in with bloody diarrhea on my feathers, right? These are really critically ill AHDS patients. What about that dog that comes in or that cat that comes in, has diarrhea for a couple of days? Should we specifically be using antimicrobials like metronidazole, or does it make a difference?
Oh, that is a great question. And they're now mounting numbers of studies. There was actually recently analysis of that, a review that went over a number of different studies in the veterinary literature looking at that question, either metronidazole compared to just supportive care, or metronidazole compared to a fecal transplant, or metronidazole compared to probiotics, or whatever it might be. But just about all of the evidence, all but one study, I believe, show that it really doesn't help to give them metronidazole. They get better just as quickly and do just as well with the other stuff. And I'll say the other stuff because, it depends on which study you're talking about. But something like sending them home with a change in the fiber in their diet and a probiotic or maybe a prebiotic is going to be much better antimicrobial stewardship, because you're absolutely right. Antibiotics change your microbiome and all of your microbiome, not even just in your gut. They're changing it in your bladder, and they're changing it in your nose, and they're changing it everywhere in your body. So we have a growing compilation of literature. It was reviewed recently by Katie Tolbert, as a matter of fact, in Topics of Companion Animal Medicine, that show it's not a great idea to use metronidazole for just a dog or a cat with an acute onset of diarrhea, for the most part. There are definitely exceptions. You mentioned them. The animal that's leukopenic or hypoglycemic or has persistent hypotension, even though you've given it appropriate fluids to make sure that you've corrected issues of volume or hydration. Those animals probably should get antimicrobials, and in that case, metronidazole is a reasonable choice. But for most animals that either have just an acute onset of diarrhea or acute hemorrhagic diarrheal syndrome, formerly known as HGE, they don't need to get antimicrobials, and they don't need to get metronidazole.
Awesome. All right. So if you only take one thing away from this VETgirl podcast, please stop using metronidazole with acute diarrhea. Okay. We've been saying this for at least 2 years, and I still see it happening all the time. All right. I have 2 more questions on antibiotics, and then we'll move on. The first one, and I remember one of my good friends had an injury and they were going into urgent care. And I said, make sure to take that oral ibuprofen before you go, versus like being charged $200 for them to give you an oral ibuprofen. They're like, really? I was like, yeah. Same thing with antimicrobials. IV and rofloxacin, IV certain drugs, when it comes to antimicrobials, can be really costly. Does a patient that is hospitalized need IV, or can it get an enteral source, which may be less expensive?
Yeah, that is a great question. And I won't say that we have a big bunch of literature in veterinary medicine to look at that, because we don't, at least that I'm not aware of. But I've gone to talks again at our medical school here at Mizzou. We have a medical school as well, the veterinary school. So once a week, I get to go to grand rounds for the human medicine, look at the internal medicine rounds. And there was a whole grand rounds topic on parenteral versus oral antimicrobials. And the end result was, if the animal can keep it down, if there's no reason that they're having, profuse vomiting or regurgitation, there's no reason to think that their stomach isn't being perfused or their gut isn't being perfused, it's just as good to give the oral antimicrobials. There's not an inherent advantage to using parenteral antimicrobials. So even for people, and because this was a people talk, even for people with things like bacterial endocarditis, they could give them oral antimicrobials. Now, I still know that people with endocarditis sometimes get IV antimicrobials. It does happen, but the evidence was presented in this grand rounds that shows that it doesn't necessarily have to be IV. So certainly if an animal can't keep an oral down, if they've got vomiting or regurgitation or something along those lines, yeah, give them the parenteral. Or if you think their gut isn't working and isn't going to move out of the stomach, it isn't going to get to where it needs to go, that would be another indication to give them parenteral. But I think there are plenty of times where we choose parenterals where we could choose orals and be just as effective.
Great point. There's lacking literature or evidence-based medicine on this in vet med. And I will say, where I trained at Angel Animal Medical Center in Boston 25 years ago, They actually had a policy where you weren't allowed to administer oral medications in the ICU.
Really?
And it was interesting, but the philosophy was it takes a lot of tech time to make sure that pet actually swallowed the med. And sometimes they were concerned if it was like an ITP, it was bleeding into its stomach. They didn't know if the drug was being absorbed, but it was more from a labor aspect. I think that's changed because that was 2.5 decades ago. I think we have to look at that patient population, right? So as a criticalist, the patient population that I see is going to be very, very different from what you're seeing in general practice. So like the critically ill, post-op, regurging patient that's a septic peritonitis, that's a patient I'm still going to obviously continue parenteral medication. But when in doubt, a lot of these patients that you're managing in day-to-day urgent care or general practice, you can treat them and it's a lot less expensive or more cost effective for the pet owner to have that enteral. So when in doubt, don't doubt the power of that. All right. I wanted to bring it back to vaccination a little bit. We all hate when someone contacts us on, Facebook that we haven't talked to in 30 years. And they're like, oh, my cat was just diagnosed with X, Y, and Z. And I remember having a colleague or a random high school friend who reached out and their 19-year-old cat that was an indoor cat in a high rise in New York City came down with Pan-Luc. And the reason why was because they were fostering kittens. And that cat hadn't been to a vet in 19 years, right?
Yeah.
So talk to me about vaccinating cats, specifically ones that are maybe indoors. Should we be vaccinating them for feline leukemia every year? Or what do the newest guidelines really tell us? Is it core, non-core? What should we be doing?
Yeah. So the 2020 AHA AAFP guidelines, and they were done jointly with those two groups, classify feline leukemia vaccinations as core for kittens, but not core for the rest of the cat's life. After you vaccinate as a kitten and then you booster when it's 1 year old, for the rest of its life, it becomes an optional vaccine or a non-core vaccine for adults. And that means it depends on the risk of exposure. For a cat who is a barn cat and it's roaming around outside, yeah, vaccinated. Or a cat who lives in a house with other cats that either have feline leukemia or they're unknown, like a foster cat. You're bringing in new cats that might have feline leukemia. Yeah, go ahead and vaccinate it. But if that cat had been in the high rise and they weren't fostering, there's not a whole lot of risk of getting feline leukemia. Remember, with feline leukemia, cats are by far most susceptible when they're young kittens. Once they make it into adulthood, they are much, much less likely to come down with feline leukemia, even if they're exposed to another cat with feline leukemia. And remember, the exposure has to be fairly close. It's predominantly transmitted through the saliva. So that's why cats have feline leukemia, give it to their kittens when the queen is grooming them and loving on them and, nursing them. That's sharing all the bodily fluids in a way that she's quite effective at infecting her own kittens with feline leukemia. The two cats who live together that aren't particularly close, and there are definitely cats that live together and are close and groom each other, but many of them are like most of my cats, they kind of ignore each other. It's like, you stay over there, I'll stay over here. We don't have to have anything to do with each other. The risk of them transmitting feline leukemia to each other is really quite slim, even if one of them had feline leukemia once they are adult cats. So vaccinating in kittenhood, vaccinating at that first booster when they're 1 year old, yeah, that's core. We should do that for all the cats, but we don't necessarily have to revaccinate them every year. I will say something about older cats, like your friend's cat. We've all seen the situation where someone has an indoor cat who's truly been indoors. Maybe they haven't fostered. It's been indoors all its life. It's 15 years old now, and it develops lymphoma or some other manifestation, anemia, feline leukemia. And the owner says, but I tested him when I got him, and my cat tested negative, and he's been in the house the rest of his life. That can't possibly be right. It can possibly be right, because there are three potential outcomes from feline leukemia exposure. One is that they can be exposed to a cat with feline leukemia and have an abortive infection. That means they fight it off. They never get feline leukemia. They never test positive. They never have any consequences. They're just in the clear. They can also have a progressive infection. They're exposed, they get feline leukemia, they get viremia, it incorporates into their cells, and they're going to get illness associated with feline leukemia at some point in time. Doesn't mean they're going to die from that illness. You can often treat those illnesses, but they're going to get feline leukemia, and they'll probably have a shorter life than other cats. The third consequence is a regressive infection. So those cats, they were exposed to feline leukemia, they had a viremia, they partially fought it off, they kept it confined. It's inside of cells in their bone marrow, for instance, but they stopped testing positive. And they usually live a fine, long, healthy life, and they die with feline leukemia, not from feline leukemia. But for some proportion of those cats, it's been hiding in their body, and it could hide for 5 years or 10 years or 15 years or 20 years, and maybe they die with it, not from it. Or when they get to be 15, it could come out of hiding. It could cause consequences. And in fact, there are ways it could cause consequences even without coming out of hiding. They still test negative, but they may develop lymphoma even though it's still testing negative. And if that cat would be used for a blood transfusion, hopefully you're not using your 15-year-old cat as a blood donor, but if it would be used for a blood transfusion, even regressive cats can pass on infection, and the cat that receives their blood can develop a progressive infection, which is why all blood donor cats don't need just a point of care test that says they're serologically negative. They need to have a PCR test. They need an RT-PCR to show they're truly negative, because you don't even want to use a regressive cat as a donor, even if they might live the rest of their life without any problems.
Wonderful. Great information. Thank you. Now, I wanted to bring up a topic that's sort of near and dear to me because I live in Minnesota, where it's winter 6 months of the year. And it's making sure that we get our whole team on board when it comes to appropriate preventative medicine. Because sometimes I will hear the doctor say, yep, your dog should be on year-round, or your cat should be on year-round preventative. And then I hear the pet owner walk up to the front and I hear them say, oh, you only need 6 months. Right? So, especially since I live in a cold area, can we stop heartworm preventative and tick preventative when it's cold outside?
No, we should not. I think that it's less likely that they get a mosquito bite in the dead of a Minnesota winter. They certainly could still get a mosquito bite in a Missouri winter, or a little bit south of you. But ticks, and fleas for that matter, are not just winter. Rhipicephalus sanguineus tick, for instance, the brown dog tick, it's found all over the world. It actually likes to live indoors. So these are ticks that sometimes they're called kennel ticks. They'll live in floorboards, they'll live in walls, they'll live in attics. And by living indoors, they manage to survive year round. You can find ticks in the dead of winter, especially Rhipicephalus, but other kinds of ticks too. So we really should continue our heartworm prevention and our flea and tick prevention all year long. It only takes one bad bug to transmit potentially very serious illness to animals. So we should be giving that heartworm, flea, and tick prevention 12 months of the year, not 9 months or 6 months.
Great. Thank you so much. Now, I did want to mention another thing that you guys renamed. Instead of IBD, now a lot of times it's called CIE, or chronic intestinal enteropathy. And I wanted to talk specifically about a subset that I see quite often in Yorkshire Terriers. And it would happen so commonly where I'd be looking through the referring vet records. I always say, if you have ever filled metronidazole for a small Yorkie more than once or twice in the past couple of years, that dog has undiagnosed PLE, protein-losing enteropathy. Yeah. And unfortunately, by the time I saw them in the IC or ER setting, they would have severe pleural effusion, severe, almost a pure transitate of severe ascites. And it's because they were so hypoalbuminemic. They'd have an albumin of 0.7. A lot of these situations, I would see secondary complications of pulmonary thromboembolism or terrible clots. So we oftentimes will treat these guys with platelet inhibitor drugs because we know they're hypercoagulable. So big question. Can we stop some of these platelet inhibitor drugs once that albumin or that total protein normalizes with PLE or PLN? Can it stop cold turkey? Should we wean them off? Or do we keep them on these medications for years?
That is a fantastic question. There was a paper on this that was published fairly recently. Dr. Amy Dixon published a paper in JVIM. And what she did is she looked at dogs with protein-losing enteropathy by thromboelastography or TEG. And she checked these dogs before their albumin normalized and after the albumin normalized. And I can tell you for years and years and years, I taught and I did that once their albumin was okay, we could stop using the thromboprophylaxis because they lost antithrombin with the albumin. They're about the same size. They're about the same charge, when we're talking about kidneys and PLN. So my theory was, why keep going with thromboprophylaxis once the albumin is normal with either PLE or PLN for that matter? But she looked at PLE, and what she found is even after their albumin had normalized, they were still hypercoagulable by TEG, which suggests that we should not be stopping the thromboprophylaxis. We should keep going probably forever. Now, that was protein-losing enteropathy that she looked at, those Yorkies with the lymphangiectasia. She didn't look at protein-losing nephropathy. I'm not sure that there is a study. I don't know of a study at protein-losing nephropathy, but it has to make me wonder if the same thing is going to be true for protein-losing nephropathy. So for both of those diseases, I used the albumin as my marker. Once the albumin was normal, I felt like I could stop the thromboprophylaxis. I don't do that anymore. Now it's like once it started, it's going to keep going. Luckily, the thromboprophylactic drugs like clopidogrel are not terribly expensive anymore, and they don't have a whole lot of adverse effects to deal with. But I think we need more studies. We definitely need more information, especially on the PLN. But I think I've changed my mind. I now know better, and so I hope I'm doing better.
Hopefully I won't offend anyone in academia, but I always joke that TEG stood for totally expensive gadget. Most GPs don't have these, right? Like even specialty clinics in private practice sometimes will have them. So the unique thing about this is like, there's not an easy way for us to test for hypercoagulability. Remember the ability to like throw clots more readily. When we're testing with a PTT, we're testing for hypocoagulability, right? And typically we don't see that until significant factor deficiency or loss occurs. So unfortunately, in general practice, in emergency practice, in urgent care, you may not have a TEG or a way of testing for hypercoagulability. But the awesome thing about this study is it just goes to show some of these patients should be continued on their Plavix or whatever you're using for a longer duration of time, just because it's hard for a general practitioner to be able to test for that. I don't even know if it's a send out anymore, but I think you may be able to find abilities to test for it. All right, the last thing I want to talk to you about, and this is super controversial right now, fluid therapy. We talked about it a little bit, and we'll end on fluid therapy. I think we talked about it in part one where we, 30 years ago, we were taught 60 to 90 mils per kg for shock doses. And the hard thing is we have slowly reduced or been more cautious when it comes to using shock doses in our critically ill or emergent patients. And I emphasize that this is especially important in patients with pulmonary contusions, right? Because any patient with lung disease or with a really injured lung or alveolar spaces from that trauma of those pulmonary contusions or being whacked by a car, they're more likely to potentially fluid overload. So we really become more cautious with using that. The hard thing, before in part one, I talked about, in general, if you have healthy kidneys, you're not going to volume overload unless you have cardiac disease, right? So cardiopulmonary disease, kidney disease, we're definitely going to be more cautious. But if you're like a young 2-year-old healthy Labrador, you have normal kidneys, you're going to handle that volume. The question is, what do we do in those patients that we see that are acute kidney injuries?
Yes.
How do we treat them? Because by the time I get referred them, they're edematous.
Yeah.
And I know like in places that do hemodialysis, they don't want them when they're edematous, right? So what do we do in that situation?
Yeah, and I will not pretend that I have all the answers. I think we need to be learning a lot more here about exactly how to treat them. But you're exactly right. If their kidneys aren't working to get rid of the fluid, especially with acute kidney injury where they may be oliguric or worse than that, anuric, and we're pushing the fluids in, and then we end up with a fluid overload, we're going to have a lot of really hard problems that there's no good way around. It's not easy to necessarily give diuretics and have a response. Sometimes you have a response. So, if they're fluid overload, you certainly might try doing that. It might help you, but there's not any easy way to fix the fluid overload. So we need to be more careful to try to prevent the fluid overload whenever we can. Now, for years and years and years and years, I would push IV fluids as hard and fast as I could get away with, until they started showing those early signs of fluid overload in an effort to try to drive out uremic toxins and somehow increase the GFR, even in animals that I had made up for their dehydration and they didn't have hypovolemia. But it turns out I wasn't doing anything to increase their GFR. Giving them extra fluids does not increase their GFR. That is not the way that we should be trying to deal with kidney failure. Instead, with kidney failure, we need to be doing things like treating the underlying cause if we can, like leptospirosis. If they have leptospirosis, then an antimicrobial may be helpful in treating those animals and addressing any of their electrolyte disorders and trying to make sure that we take care of the electrolyte disorders and treating the things that are treatable without just pushing the fluids and hoping that that's going to somehow make the GFR better. It doesn't. Now, I can say from my own personal experience, my husband's been dealing with a lot of health things. He's had a few episodes of pneumonia and ended up in the hospital, and he had acute kidney injury associated with some of the contrast studies or some of the antimicrobials that he had. And they had him on these rates of fluids. And I'm like, what the heck are they doing? This is malpractice. You're thinking of like 50 mLs an hour. And he's a fairly decent sized guy. I thought he needed to be on a lot more than 50 mLs an hour. But that's not how it works. So I started looking at the human literature, and now with the new, really nice guidelines that came out on fluid therapy for AHA, they say the same thing. We're not going to be able to increase the GFR by pushing fluids to already hydrated animals. So we need to do things differently. We need for them to be euhydrated, and we need to get them to be normovolemic, but then we have to concentrate on things like treating the underlying cause of the kidney injury, treating the electrolyte imbalances, measuring and managing blood pressure so they're not hypertensive. And by the way, hypertension doesn't necessarily go with what's going on in the kidneys at the same time, but kidney disease causes a lot of hypertension. We have to watch the sodium load that we're giving them and the chloride load that we're giving them. Then we have to provide nutrition, and then we give them time. And if it's acute kidney injury and we can buy them time, the kidneys can do a lot to heal themselves. So it's a little bit like our old treatment of pancreatitis, which has changed now a little bit with new drugs. I used to tell the students that we didn't have any way to treat pancreatitis. Maybe there is now, but there wasn't. There's no way to treat pancreatitis. Instead, we try to keep them alive until God can fix their pancreas. And it's a little bit the same with the acute kidney injury. We want to keep them alive and keep them supported and let time work on fixing their kidneys.
You bring up such great points. The one area that does drive me nuts, though, is the big movement right now to not use fluid therapy in the poison patient. And I've been working and talking with a couple other toxicologists, specifically Dr. Tina Weissmer, who's the chief medical officer at ASPCA Animal Poison Control Center. And I hear criticalists saying you shouldn't use fluid therapy with a poison patient. And I'm going to vehemently disagree. And the main reason why is because sometimes it's not for the GFR, but it's to clear the renal tubules. It's to counter the potent vasoconstriction from NSAID toxicity. And while fluid therapy doesn't help with drugs that don't undergo or toxins that don't undergo urinary elimination, they can help with different aspects. So I always joke, short of an antidote, there's really only 5 treatments for the poison patient. It's bluntly symptomatic supportive care. Okay. And that boils down to fluid therapy to potentially treat that dehydration, perfuse the patient, clear the renal tubules, counter that potent vasoconstriction to the renal vessels, prevent that hypernatremia that we can sometimes see with charcoal and emesis induction. Second category is cardiovascular support, whether or not that's atropine for that bradycardia, whether or not it's vasodilators for, PPA poisoning, whether or not that's beta blockers for that severe tachycardia. The third thing is neurologic support, using things like intravenous methocarbamol, which we see a lot of tremoring from a lot of toxicants, whether or not that's tremorgenic mycotoxins or pyrethroids, chocolate toxicity, garbage gut, SSRI antidepressants. Fourth category, after fluid therapy, cardiovascular support, neurologic support, gastrointestinal support, whether or not that's an antiemetic to counter the emetic that you just used, potential prokinetic to help get that charcoal bound to the toxicant out to help with elimination, treating appropriately for their diarrhea if needed. And then the fifth category is truly miscellaneous medications. Maybe it's hepatoprotectants or antidotes or things like that. But even if it's a drug or toxicant like classic THC, undergoes biliary elimination and fecal elimination. Putting them on IV fluids doesn't really do anything, right? It doesn't help with elimination, but it does help in that patient that has poor oral intake because they're so sedate or they're comatose, they have decreased gag reflex. Maybe you gave them charcoal and that rare risk of hypernatremia that we can see. So again, you want to weigh the pros and cons with whatever drug we use, whether or not it's fluid therapy or an antimicrobial or whatever, a topical medication, anything. We always want to weigh the pros and cons. We want to weigh the risks. Is there potential detriment to using this? And to me, the most difficult cases are always the acute kidney injuries, right? Because they're difficult to treat. But remember, fluid therapy is not set it and forget it. It's looking at PCB total solids. Are they hemodilute? It's weighing them 6 times a day, even though it's a pain to lift them up and disconnect them. It's looking at their urine output. It's looking at their urine specific gravity. It's based on physical exams. So many parameters. So again, when in doubt, especially for me as a toxicologist, I always say relatively benign when it comes to fluid therapy. And personally, I have, knock on wood, have never had a poison patient personally become hypernatremic. To me, ASPCA is always saying, check sodium every 4 hours. I can't. That's going to add like $600 in electrolyte checks to my patient versus me giving them an antiemetic, giving them a bowl of water so they can drink water, putting them on, 2.5 times maintenance. But remember, it's never set it and forget it when it comes to fluid therapy. So making sure we're looking at all the parameters, weight, physical exam, oral intake, the metabolism of the drug, so many parameters to weigh. But I agree, nobody likes an overhydrated acute kidney injury patient. Yeah. We hate getting those referrals. Awesome information. Really appreciate all that you do. Love always talking to you, and really appreciate you talking about these outdated beliefs, misconceptions. Again, we practice the best that we can, right? And we all know while it's more in vogue to practice spectrum of care, this is the way we've always practiced, right? Or we've always had to practice. With the growing cost of veterinary medicine. While we would like to practice the ivory tower way, sometimes we have to adjust that when it comes to spectrum of care. But it's so important that we know the newest updates so we can make sure that we're practicing what's evidence-based medicine. Dr. Cohn, really appreciate all that you do. Really appreciate you joining us for today's VETgirl podcast.
Thank you so much. I enjoy talking to you always.
Thank you so much.